So we want to welcome you to February's annual Heart Health Month. Everybody looks great in your red. So now we're going to get started with our program. And we have Dr. Sean Malarkey, as well as Tyler Evans with us today. And we're going to learn a little more about vascular surgery.
Okay. This is working, I hope, right? All right, I'll try to make this not too lengthy and boring. My name is Sean Malarkey. I'm one of the newer vascular surgeons here at Reid Health. I guess there's been a little bit of a dearth of them for the last few years. A little bit about me. I'm actually somewhat local. I grew up just north of Dayton. I live there. My parents still live there. I went to college in Kentucky, medical school in West Virginia, and went to Pittsburgh for most of my training. I was practicing in Cincinnati for the last 3 years and then came here in October. So that's a little bit about me. I didn't wear red today, but I'm a vascular surgeon, so I wear red at the end of every day. So some of our objectives here, pretty basic stuff. Let's introduce you to, I guess, our new team of vascular surgery here at Reid. Nobody really knows what a vascular surgeon does, not even your primary care doctor sometimes. So it's important to kind of understand what we do and why we do it and why we're around, how we're involved in healthcare systems. And then I was asked to talk about vascular screenings, which is a very mundane topic, but nevertheless, we'll get through it, okay? And basically, hopefully you'll just walk away with this with the understanding of when to see a vascular surgeon if you feel compelled or if your family doctor decides you need to. I know it's kind of blurry, but this is our team. It looks like our pictures are on your little handouts there. So myself, I'm right here, and then Dr. Kwong, who's vacationing, gallivanting somewhere, I don't know where, this week. And then we have two nurse practitioners, Mary and Tanya, who help us out. So key terms that you kind of might hear passed around sometimes when you talk about blood vessel problems. The most common I talk about, and I may use these terms with patients in the room, and sometimes it's a little bit like jargon. But atherosclerosis is the most common term that I end up talking to folks about. It's a real simple thing. It's just hardening of the arteries, more or less. That's when plaque, is what we call it. Basically, you call it grummus, for lack of a better term, builds up in between the layers of an artery. Now, I put a little picture of an artery up here. If I were to cut that right down the middle, you can see it's composed of many different layers. All right. And so plaque can actually interdigitate itself in between these little layers. And that's what develops atherosclerosis. Hardens the arteries. It can also break off and go downstream in places we don't want it to be. Other things you might get screened for are aneurysms. An aneurysm is when a blood vessel that has a normal diameter or size swells, for lack of a better term, to 1.5 to 2 times its diameter. So something that's 1 inch becomes 2 inch, so to speak. And then we also talk about venous insufficiency. Insufficiency means it doesn't work very well. When your veins don't work very well, I'm sure a lot of us in this room have that problem. You get varicose veins, swelling, sometimes some aches and pains associated with that. That is globally known as venous insufficiency. All right, those are the most common things that people don't really understand. Now, vascular surgery is very antiquated, actually. It's hard to believe. A lot of it has been kind of absorbed into other specialties originally, but it kind of has 3 distinct eras in history. And this reaches way back into antiquity. We're talking about ancient Greece, Egypt, etc., where we had different techniques of managing problems with blood vessels. A lot of those were indirect techniques, as we called them. The best we could do is shut down circulation. And then we kind of moved into the 1900s and 1950s, et cetera, where we started to figure out that we could actually fix blood vessel problems by just going right at them. Most surgeons steer clear of them, but we go right at them. And now we've actually progressed even further to what we call endovascular surgery. It's minimally invasive procedures that we can do to hopefully fix blockages and treat problems in arteries. So the vascular surgeon's job, it's very simple. It's stop the leak and restore the flow. All right. It's very simple. All right. That's why I tell every single patient that I meet that I am a plumber. I am no different than that. All right. And I even, sometimes I might even bend over in the office. You might see this kind of view. But, the reality is that is all I am as a plumber. So it's as simple as that. If you got a leak pipe or you got a clogged pipe, I try to fix it for you. Okay. So how do we stop the bleeding? A lot of us, the old adage is that you put a finger on it. I always tell folks that call me from the ER, if somebody's bleeding from somewhere, put a finger on it, all right? Just keep it there. Don't look at it. All right, that's the simplest way to stop bleeding. You know this, you might have heard about this in this sense that if you've ever been in watched television, seen folks out in the real world that get injuries from various reasons, car accidents, whatnot. Any bleeding can be stopped with direct manual pressure. We've gotten kind of fancier through time, like I talked about. We learned how to tie off and completely stop blood vessels from bleeding. And we've also learned through time to actually use various catheters and wires and stuff inside blood vessels, and we can plug up the bleeding, so to speak, with little coils. And then we restore circulation. A couple different ways we can do that. Like I said, we do have the ability to put stents in folks. If you have a clogged artery, blocked artery, stents can wick open as a scaffolding and restore blood flow to an area of tissue that wasn't otherwise getting blood flow. We also reserve the right to do what's called a surgical bypass. Now, most people think bypass surgery, they think of your heart, but a vascular surgeon deals with everything else but the heart and the brain. So every other blood vessel in your body is something that I might work on. Now, those problems are a little bit more on the rare side, but they do exist. So some folks, you might even know somebody that has a bypass or something like that, or if had stents put in their legs or arms, etc. That's something that I would do. Our training is very defined. Most people go to college. You don't have to get a bachelor's degree to go to medical school anymore. Interesting factoid. But you have to have a certain amount of time. Usually amounts to 3 or 4 years. We go to medical school for 4 years, most of us, in various locations. I'm an osteopathic physician. I went to an osteopathic school, but you can go to medical school, become a medical doctor, all the same. We are the same. And then you spend time training. So I spent 5 direct years training, so that's 5 extra years. Or you can do what my partner did, 5 years and another 2 years in fellowship. All in all, it takes 13 to 15 years of after high school to become a surgeon, okay? So it's a lot of time spent, a lot of wasted of your 20s. Don't spend a whole lot of time in the bar when we're young. In terms of health system integration, so if you go to websites and see things on TV, you see heart and vascular, right? And we're always the redheaded stepchild of that group. Heart surgeons and cardiologists are probably the most important part of that group, but vascular surgeons make up an integral part of that team, and that's kind of where we fit in the health system model. We are at the bottom, but that's okay. We're happy to be there. We're blue-collar type folk. And the reality is that we kind of call ourselves the firemen of the hospital. We put out fires. We fix people's problems. So we serve to fix complications that happen in the operating rooms. Other folks that are working in areas that are close to blood vessels, they nick it or perforate it. We go in and we help them fix it. We also do that in the cath lab too. So if anybody's ever had a heart stent put in, you know that they went through one of your blood vessels to do that. Sometimes those cause problems, and sometimes that problem can manifest in a real significant issue that requires a vascular surgeon to fix it. We assist with other surgical procedures. Some folks need us to kind of get in there and move stuff out of the way so they can do their business. Most common issues like urologic issues, people with kidney problems, or with folks that have spine problems. We actually expose the spinal column for bone doctors to actually fix your spinal column with whatever they need to do. We move everything out of the way. But also vascular surgeons have been kind of smart enough to serve in director roles in various locations and throughout the hospital. For instance, if you go to get any one of these screenings or tests, usually the director of that laboratory is a vascular surgeon, which incidentally, I've been elected to that position myself. So, so that's how we kind of integrate ourselves into the healthcare systems. I guess we'll get to the nitty gritty of this stuff. Like I said, it's very, very mundane, but you're composed of arteries and veins. And how do we screen and kind of diagnose problems associated with that? It's real simple. Arteries it's kind of a one-way system, right? So arteries take blood one direction and veins return it the other direction. It's real simple. Now, everybody kind of thinks about, is blue vein or is red artery? Not always. But the theory is that arteries will take blood that has oxygen in it, which gives it that red color, and it will distribute it to all the organs and tissues that you need to survive. And arteries can expand, they can get bigger, they can get smaller, and do whatever is needed to do to improve that blood flow distribution. They're under an immense amount of pressure. When somebody's measuring your blood pressure, that's exactly what they're measuring. They're measuring the ability of the artery to squeeze and contract blood as it moves in towards the healthy tissue that you're trying to supply. So for that reason, there's a fair amount of muscle. You saw that diagram of what the artery looked like. There's a lot of muscle incorporated in that blood vessel to allow that to be distributed. Veins, on the other hand, veins are plentiful. They can regrow to a certain extent. They take blood that has been passed into the healthy tissue and they redistribute it ideally back to your heart. The idea is that you're returning that blood that has dropped off its load of oxygen and healthy nutrients to that part of your body, and you're taking it back. Veins also kind of take all the gunk out of things. So if somebody's trying to heal a wound, your wound breaks down and kind of causes some gunk to kind of build up inside of that. Veins do that. They take away a lot of that bad material and redistribute it through your body so your body can actually take care of it and help heal the wound itself. They don't contract as much, which is why they swell, unfortunately. And that's kind of where we'll get into that venous insufficiency, that varicose vein situation. Those veins can kind of get quite big, unfortunately. We'll try to break this down very simply. I try to go, for me, it's easiest just to go through, a top-down approach. So in terms of screenings, what you might get as part of that screening, that $29 thing, that somebody will look at your carotid arteries. Carotid arteries are in your neck. Now, if your family doctor takes a stethoscope and puts their stethoscope on your neck, what they're listening for what's called a bruit, a little whooshing sound. That's been kind of debunked over time. It's not really a good way to assess your circulation in your neck. If there's any sort of concern, then that's where the screening kind of comes into play. But the function of your carotid arteries, I don't know if anybody knows anybody that's ever had that worked on before, is they supply the blood to your brain. They keep you functional for the most part. They're located in the neck here. You got a big muscle in your neck. If you can grip that muscle, it's right behind it. And some of the issues associated with that, they are mainly related to trauma. We talked about atherosclerosis. They can, although rarely, get aneurysms where they swell. And then the issue is stroke. That's the main issue that we are all concerned about with the carotid arteries. As they narrow down, they can cause a stroke to the actual hemisphere or side of the brain that they're supplying blood to. I don't know, it's always worth reviewing the signs and symptoms of stroke. These are very common things that happen, unfortunately, and you may be with somebody that might experience a stroke. We always use the acronym called FAST. It's where you're looking at somebody's face, their arms, and their speech, and trying to determine if somebody's had a stroke. Face, the main thing is that one side of your face might droop. Your speech might get a little bit garbled as well. And in terms of arms, we're looking to see if your arms have equal and appropriate movement. If one arm's kind of lagging at the side, you're concerned about one side of your body being weak or numb, those are signs and symptoms of stroke. And you need to kind of come to the hospital because that's where the T comes into place. Time is brain, as we say. It's a very, very urgent matter sometimes to get evaluated for a possible stroke. That's just a kind of a pictogram cartoon version. I put a lot of pictures in this because honestly, I can't talk off words. It's boring. But, just always, fast. That's the simplest thing. So screening. So screening with vascular problems is not mandatory for a lot of things. All right. So I just want to be very clear about that. I think it's great what Reid does. These little screening examinations are very helpful. I myself read these tests and I've seen a fair amount of issues arise. But screening is typically reserved for carotid problems when you have a symptom or sign associated with it. Now, certain folks are a little bit higher risk. What does high risk mean? If you have had high blood pressure for a long period of time that was hard to control, somebody that has a strong smoking history, so you're consistently smoking every day, or you have a really strong family history of stroke, it's totally reasonable to screen for this problem. As I said, and I listed some of those criteria there. Diabetes can also be sort of an association with buildup of that plaque and atherosclerosis in your arteries. So if you do get this screened, what they'll do is they'll use an ultrasound probe, and that probe is directly looking at the artery itself. The artery, I have some pictures of it, but I'll show you exactly what the artery looks like under the ultrasound and also just in general and what they're looking for. So there's basically a fork in the road. This is the reason why people develop blockage in this area. So you can imagine coming to the fork in the road, whether it's a Robert Frost poem or your actual life. Sometimes it's hard to make the right decision, right? Think about this as like a creek or a stream that's split into two. If you ever look at that stream, if you ever look at the actual crux, right at the actual corner there, you might see that there's a lot of eddies. The water doesn't really know what to do exactly. Same is true in your blood vessels. This blood moves hopefully uniformly up into two different blood vessels. One goes to your face, this one on top here, and one goes to your brain. That's the more important one. But unfortunately, blood kind of has a hard time thinking about what to do. And so in this area, those eddies can cause trauma and damage to the artery over time. It's a flaw in the system. That's just the reality of what it is. But those flaws can be accentuated by those risk factors that I already went through. But that's what they're looking at with the ultrasound. You might be laying down flat, and they're looking at both of these arteries and trying to see if blockage is building up in this area where those eddies might be working out. And that's literally what they're looking at on this screen. This is what I look at too when they take your pictures of it and send it over to our computers. They're looking at where this fork in the road is splitting, and we're looking at the dominant blood supply that's going to your brain. I don't really care about the one that's going to your face. That has a lot of extra blood supply. It's not that big a deal. It's the one that goes to your brain. And so they're looking at it in multiple different points of view during the screening examination to see if there's any blockage that might be building up. And the way we kind of determine whether or not that's there, you kind of can see it on ultrasound, but it's not really good. We're actually measuring how fast blood is moving through there. So think about putting your thumb on the garden hose. If the hose is wide open with no nozzle on it, right? Blood kind of moves through in a very steady stream. You put your thumb on that garden hose and you narrow that lumen down quite a bit. What happens? Water goes shooting through there at a lot higher speed, a lot higher rate. It's exactly what we're doing when we're measuring the blood flow in your neck. It's real simple. Like I said, it's plumbing. Your aorta. This is the other one that might come up when in the screening examination. You can develop blocked arteries as well all the way down your tree. Any blood vessel that you have in your body, anybody can get a clog in it, whether it's a blood clot or the atherosclerosis situation. The most common situation where somebody's going to get screened for their aorta is usually going to be the aneurysm issue. But what does the aorta do? It comes out of your heart, up in your chest, and it distributes blood to all vital organs and down your legs, to your arms, etc., on its way down to around your belly button where it splits and goes down your legs. It's located mainly in the chest and abdomen. And like I said, aneurysms or hardening of the arteries, again, atherosclerosis can happen to this blood vessel. Screening is a little bit more defined here. So I have my own screening paradigm that I follow based on a society that I'm a part of. Now, there are Medicare and Medicaid do follow other rules. They're similar, but not exactly correct. So some of this information may be accurate for what you might get and what might not get. It kind of depends. But the reality is that anybody in the 65 to 75 range that has ever smoked or is still smoking should get an ultrasound to look for an aneurysm. That's if you're older than 75 and in reasonably good health, we expect your life expectancy to be probably more than 2 years. It's also reasonable to get an ultrasound, a one-time ultrasound to look for an aneurysm. And the other issue too is that first-degree relatives, there's a high relationship between family members that have aneurysms to warrant reasonably screen for an aneurysm. So if you know somebody in your family, usually it's going to be a first-degree relative, either a parent, a child, or a sibling that had an aneurysm in your belly or your chest. It is actually worthwhile for you to go get screened for an aneurysm. And how they do it, this is how we all look, I'm sure. Once again, an ultrasound is the best screening tool here. The reason why is it's pretty inexpensive comparatively. It does not require any radiation or dye. And as long as you can see it, it's usually a pretty good evaluation of an aneurysm, because all we're looking at is really the actual wall-to-wall diameter or size of the aneurysm itself. Now, the caveat to this, and this is what kind of gets people, is that everyone kind of assumes that it's in your belly. It's not. Your aorta is actually closer to your spine, closer to your back, but you can't really image and use ultrasound through bone and muscle very well, so that's why we look at it through the front, okay? And that's why it's important, if you do get one of these screening examinations, it's important to fast at least 6 hours before you get that test so that there's not a whole lot of air and stuff in your intestines. But this is kind of how you do it. And like I said, if you take a look here, this is what's a normal blood vessel, and this is an abnormal blood vessel. You can see it's ballooned up like a grapefruit. And the reason why it happens here in your belly, and this is around your belly button, so if you know where your belly button is, that's about where the blood vessel here splits. This is the furthest point downstream of the aorta, and it's unfortunately the weakest part of the aorta, and that's why these aneurysms tend to develop there. As we get older, or if we do things, if we are not controlling certain risk factors, this area can swell. And so, like I said, here's your belly button, here's the actual split part where it goes down your legs. This is the ultrasound where they're going to look right there and try to see if they can see whether or not there's any sort of swelling or abnormality in the aorta that might look like an aneurysm. And that's what it might actually look like on an ultrasound test. It's very well defined. Where there's when you see something black on an ultrasound, that typically means it's fluid or blood, and then the soft tissue around it. A lot of these aneurysms over time develop what's called calcium, which is no different than calcium you might see elsewhere. It's a hardened material and around the actual border of it, and really defines the border of the actual aorta. It's a very useful tool for screening. And if unfortunately you are found to have one, it's important to know that they're not fixed all the time. All right, we've studied this very extensively throughout the years. It was studied a lot, not only here in the United States, but also in the United Kingdom in the early 2000s. And they took folks with various sized aneurysms and actually just watched them over time and saw what happened. And what they found is that there is a critical point, typically around 5 to 5.5 centimeters, where rupture of the aneurysm is a higher risk. And that's where it goes from being a low risk to an exceedingly high risk. And that's the major concern with these, is that, for lack of a better word, they are like balloons. And so they're as the balloon gets bigger, right, the actual material that is the balloon itself starts to get a lot thinner, and popping becomes at an increased rate the higher it gets. That's really what's happening in the blood vessel. So that's why we monitor these quite frequently. And so this is kind of the generalized plan that we have in place for most folks that have an aneurysm. If they're less than 3 centimeters, we kind of don't really worry about those too much. But once you start getting to 3 centimeters, we have a very defined protocol for monitoring these. Now, the caveat to that is that usually women do have a higher risk of bursting or rupture at a lot smaller rate. So that's why in my practice, if it's about 5 centimeters and you're female, I will consider fixing that for you, okay? Men, I tend to wait a little bit longer because of just the data supports that. Now let's go down to your leg arteries. So this is another part of that screening protocol. Your leg arteries distribute blood flow to mainly your muscles, some nerves, and also the healthy tissue in your legs. They help to, and they're located mainly in the pelvis, thigh, calf area, and also into your feet. And that, but the same issues that can happen to blood vessels in your legs can happen in the carotid arteries and also the aorta as well. You can have hardening of the arteries, which is the most common reason for folks to come into my office. Aneurysms can happen in your leg as well. And there's always trauma as a grab all for anybody that gets injured. And then we can also have other issues that are inherent in just our bodies, which are called vasculopathies, which are usually inflammatory disorders, and I'm not going to really speak about that. But symptoms related to lower leg circulation issues are pretty defined and follow a pretty typical path. A lot of people have discomfort when they walk. That's pretty normal. If you walk an extensive distance, you're going to be sore. That's pretty normal. Everyone builds up lactic acid, which is that sensation that you feel in your legs and wherever in whatever muscle group it is. That's a very normal thing. The issue is when you diminish the blood supply to the area. Remember, blood supply gives healthy oxygen to tissue. If you diminish that by having a clogged artery, a blocked artery in an area that's distributing to that muscle, then that frequency, or that, I guess, rapidity in which that happens is quite quick from some folks with this issue. So that's what we call claudication. It's a Latin term, but it basically means that muscle is starved of oxygen. And like I said, everyone gets that to a certain degree, but when you have lack of blood supply, direct blood supply, that happens a lot faster. So that's the first kind of line of problems that folks can have with blood vessel blockages in their legs. It's important to know, though, if any of you experience this or have experienced this or been diagnosed with this, it does not mean that there's any higher risk of, let's say, losing your leg or an amputation. That's one of the most direct conversations I have with folks in my office who, let's say they can walk a football field, but they start to get pretty sore after that, or maybe 50 yards. And they're worried about, am I going to lose my leg? No. The risk of an amputation is about 1% to 2% in somebody with claudication. That's about the same as my risk for an amputation, because honestly, I could get in my car, drive down somewhere, get in an accident, and lose my leg. That's how that's related to just the general population. So that's important to understand. However, it can progress over time if certain risk factors like the smoking, the high blood pressure, sometimes diabetes as well, are not appropriately monitored and managed. It can progress to other things. The folks that are really in danger of losing their legs actually have pain at rest. And that pain is pretty consistent. It's all the time. It's not, I have pain one day, don't have pain the next. That doesn't count. Rest pain is some of the worst pain that a human being can feel. That means the foot is so starved of oxygen that it just hurts. The nerves are on fire. And then you kind of progress to that really scary part of tissue loss, gangrene, and some folks can end up with an amputation. So like I said, claudication, it's a very defined muscle group that has an absence of blood supply directly. And so most people describe it in their calves, but you can also have it in your hip, thigh, buttock area as well. And then rest pain, like I said, is foot pain. It's foot pain. It's not ankle pain. It's not calf pain. It's foot pain. It's the area furthest from the heart, furthest where the blood has to move in the most direct pathway. It's foot pain that happens all the time. In fact, your foot may even turn a little bit beet red. Feels good to dangle it over the bed and almost like you're letting gravity do a little bit of help for you. It's pretty consistent. And this is the bugaboo that scares everybody. And it should, because it is a little bit unnerving. This is something that we see a lot in our office is folks that unfortunately deteriorate to the point where they start to lose a complete circulation to their tissue, and their tissue has to be amputated as a consequence. Otherwise, infection could set in. This is an example of gangrene. So screening. Screening is typically still going to be reserved for if you ever had symptoms. Like I said, our screening that we offer here is great because it kind of just gives you a generalized idea. But screening is typically going to be reserved for folks that have symptoms that are consistent with what I've described. And we typically use 3 different types of screenings or tests to look at your circulation. The most common thing that you can do and the easiest thing that you can do is actually measure the blood pressure in your ankle. And that's what's called an ankle brachial index. Ankle, that's pretty easy to understand. Brachial means arm. So we're measuring the blood pressure, comparing it to where your arm. Arm arteries are vastly under-affected when it comes to blood vessel problems as compared to the legs because they're closer to the heart. And so relationship between the blood pressure in your arm and the blood pressure in your ankle is a very useful tool for understanding whether or not somewhere down the pathway there might be a blockage limiting blood flow. We also measure the actual volume of tissue or girth, so to speak, in your legs. Because as blood moves through, like we talked about, your blood vessels can swell and dilate. When they do that, they push stuff to the side a little bit. So that changes the volume in your legs, in your thighs, in your calves. And so sometimes if you get these screening examinations, they put a whole bunch of blood pressure cuffs on your legs, and we're actually measuring the volume of tissue expansion. And then you can also get ultrasounds that directly look at the named arteries themselves. But a lot of times we reserve that for folks that have had a procedure done, and we're keeping an eye on that procedure, so to speak. That's probably not going to be part of your screening protocol unless something unusual were to show up. And so when I talk about the ankle brachial index, this is a pictorial of what it might look like. And if you ever get to see the sheet they do, if you ever have this done, you might even see this sort of cartoon man or woman on there and specific points of interest as well. But really, and this is so blurry, I apologize, but I was going to point to the numbers up here as to what's important. If somebody measures your blood pressure in your ankle, you want it to be the same as the blood pressure in your arm. That's the simplest thing. So if you were to put that number of your ankle on top of your number in your arm, those should be equal. And so that ratio, it should be 1. That is perfect. 1 is perfect. If it's slightly less than that, that's okay too, because that's the farthest place from your heart and your legs. So even if it's 0.9 or 90% of normal, that's okay too. When it starts to dip way down there, like 50%, 40%, 30%, that's when you start to get a little bit nervous that there maybe is a true problem that needs to be evaluated. Now, unfortunately, as we get older, this is just the hard truth, our arteries get quite thickened and hardened. We talked about calcium buildup in blood vessels. When they do that, they become less pliable. And so they can't be squeezed down. And so the blood pressure in your ankle can't be measured. So sometimes if you ever get this test and that ratio is really high, like 1.5 or something like that, that just means it was not a very good test and it's non-diagnostic for this problem. Okay. But that's why they might do the other blood pressure cuff tests. Like I said, that volume analysis, because that actually tells you just as much about what's happening in your tissue. So folks that might get a lot of blood pressure cuffs put on their legs for this reason, we're looking at the actual volume of distribution of blood flow in the leg. And we like to see a nice kind of fluid movement of blood. All right, blood kind of oscillates, boom, 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 boom. There's very consistent blood flow that has to move through an artery. And when it does that and it pushes pressure outwards and changes the volume in your leg, it's creating a very distinct pattern and tracing that we're looking at. All right, I'm not going to bore you too much with that, but that's just the reality. Sharp peaks good, no peaks bad. All right, that's as simple as it is. Now, like I said, we also talk about using ultrasound sometimes, and folks may end up getting one of these, but we don't use these as a formal screening test, mainly because it's labor intensive. It takes the technologist who's doing it quite a bit to look at everything. But also, it's like a snapshot. It's a picture of one blood vessel along the tree. It doesn't give you the kind of global assessment. We use it mainly, and it's hard to see on this, but we use it mainly to look at folks that have had stents put in or they've had bypasses done. Then I can actually understand how the blood's moving through there, because those interventions that we do unfortunately have a shelf life, and so we like to keep an eye on them. The last part of this, and hopefully we're winding down here, is talking about veins. So arteries, pretty consistent. We talked about that. Veins are more varied. People with vein problems come to us with a variety of complaints and symptoms, and it's kind of all over the place. It's never very specific. The things, though, that you kind of worry about we'll go over real quickly. But once again, the function of the veins is that they return that blood that does not have oxygen or very little oxygen in it, to return it back to the heart. And then it goes back and gets recycled and gets filled with oxygen, your hemoglobin does, so they can go right back out and do the same thing. And it also, like I said, removes all that bad negative products from your skin and soft tissue and everything else. And location are everywhere. So, and then the main issues that you might come and see me about, that are the most common reasons to see me about, are going to be either folks that get a deep vein thrombosis. You may have heard about that. Or, like we said, the venous insufficiency, the not working very well veins. And those kind of manifest with varicose veins, spider veins, leg swelling, lots of different garden variety of symptoms. Screening, once again, is reserved for folks that are symptomatic, so have symptoms. There's really no reason to just scan you all for blood clots. That makes no sense. You might find something you don't want to find. Let's just be honest. So you don't do that unless there are clear symptoms. The same when it comes to varicose veins. Varicose veins, all of us are going to get them with time. If they're causing problems, then it's worth doing some sort of screening element. And even then, folks that come to me with that problem, unless they have a really severe issue, I don't even scan them or screen them for anything else further, because a lot of it can be managed. But the most common symptoms, especially with blood clots, is really significant swelling, one-sided swelling. Not I'm swelling everywhere, like because I ate a bunch of salty food. Let's say one leg, one arm, something like that swells significantly. It gets so tense and tight and painful. It might turn red. It might turn blue. It's really uncomfortable. And then we talked about painful varicose veins. And the other issue is that we talked about wounds and gangrene with artery problems. Well, unfortunately, if your veins don't work very well, some folks, it's so bad of a problem that their legs don't drain at all, that they develop wounds and breakdown of their skin. So we do actually treat wounds on folks that have vein problems as well. So blood clots, deep vein thrombosis, like I said, it is a very defined symptom for the most part, especially if it's significant. And what happens is that you see a vein there, and the other part about veins is that they have check valves. They have one-way valves in which blood can move. They don't have as much contractility. They aren't as strong. So they have these valves in them that are supposed to move blood sequentially back to your heart. It's what we call a collimated system. So it has to stack on itself sequentially, and those valves close behind it so that that blood moves up or it gets squeezed upward. Blood clots can happen anywhere in your legs, and the most common area is going to be in your groin area or somewhere behind your knee. But what happens is that if a blood clot develops for whatever reason, whether it's because you weren't moving a whole lot, that's the most common reason. Some folks just have inherited reasons why they develop blood clots. If after surgery or trauma or something like that, blood clots can happen. They basically form inside the actual lumen of the blood vessel. And of course, the scary thing, the risky thing, is that they can break off and go to your lungs and give you what's called a pulmonary embolism. Okay, so that's why screening for them has become a very common feature. A lot of people go to the emergency room for leg swelling, get screened for this problem. But once again, the absence of symptoms, you don't need to be screened. We're almost done here. This is a little video, so hopefully you can see it. It's winking at you. But right inside so on the right side of your screen, that's the artery. On the left side of your screen, that's your vein. And this is what the ultrasound person's looking at when they're screening for blood clots. And they're actually pushing down hard as you can. That vein right there, that thing on the left side of the screen, that thing should be flattened out and gone. If you can't do that, you can't push down on that, that means there's something filling that space. And if it's not very clear and you can't see it, that's a blood clot. And so that's what we're looking at when they do those scans on your legs, is trying to see if there's any resistance inside the blood vessel. And it's a very useful tool. We're going to finish up here just talking about the varicose vein situation. Like I said, the main issue with varicose veins, spider veins, leg swelling is the valve issue. So as we get older, unfortunately, or if you were in a job or just your lifestyle just made you stand or sitting for long periods of time, anywhere where gravity was working against you. Unfortunately, as you stand for long periods of time, blood doesn't want to squeeze its way back to your heart as efficiently. Our muscles squeeze blood. They kind of move through as best they can. But unfortunately, with gravity, with time, blood kind of oscillates and gets pushed downward, and it pushes the wall of the vein outward. So you can see these little one-way valves, they get separated. So they're no longer meeting and closing behind the blood. They're actually they're not totally touching. So blood moves back and forth. And over time, as blood moves backwards instead of forwards, so to speak, it causes the vein to get bigger and puts pressure on everything surrounding it. And as it gets bigger, it pushes blood outwards, and then eventually causes those varicose veins that you're all very familiar with, I'm sure, because we all get them. And over time, they can cause pain because they're pushing things out of the way. All right, but that's the main issue behind this problem, and that's what we look for when we screen for this problem. This specifically, spider veins, varicose veins, leg swelling, wounds all have some relationship to this problem, and it also follows a very typical pattern. And it's very consistent for the most part. Swelling is one of the most common features that typically happens. Then you might have the spider veins. Then you might have the varicose veins. If it continues to be a problem that you can't manage on your own with whatever means, most people use compression stockings, it can, in theory, get progressively worse, cause redness, cause wounds, and those wounds can be very, very detrimental to your lifestyle because they take a very long time to heal. So the benefit of screening for that, like I said, in the presence of symptoms, is that what we're looking for is the incompetent veins that we can actually treat. The idea behind our treatment and therapy is to get rid of all those incompetent veins. And that's what the ultrasound test, which is different from the blood clot test, it's actually done with either you standing if you can stand, or you're actually put on a table where we tilt your body up. We're trying to mimic gravity, so to speak. And what we're doing is we're looking for veins that are incompetent in your legs. And if there are certain veins, then some of them I can treat by various mechanisms. And I'm not going to go into all that just now, but there are varying ways of doing that. Okay. That's all I got. But so I'm open to any questions. Anything you may have. Very boring, mundane topic. I'm sorry. But if I could leave you with anything, just remember it's plumbing. That's all it is. You're a system of pipes and tubes. That's all you are.
I have a question.
Yes.
About carotid arteries.
That
they are not addressed until they are 70 or 72% closed.
That's right.
So why wait that long?
So very good point. So the way we fix carotid arteries is that we have to either manipulate the artery itself and temporarily shut down the circulation to the brain, or we can put stents in them too, but that can also cause pieces of that stuff to break off. The idea is that you could have a stroke trying to fix it, and it's a risk-benefit ratio. And we have found through time that the carotid can get quite narrowed. In fact, I wait until about 80 to 90%. Before risk of stroke gets any higher. Because the physical act of me performing the procedure carries a risk of stroke. I quote people between 1% to 2% chance of having a stroke with just doing any sort of procedure to fix the problem. Now, that being said, as the artery gets narrowed, this has been studied, the risk of stroke goes higher, of course, incrementally as that artery gets narrowed. But it has to be appropriate. That's why we wait. So, and there's a lot to be said about how we manage these medically now. Back in the 90s, when they did all the studies and they looked at the narrowings, because technically Medicare and everybody follows the same guidelines. If you've ever had a symptom, if it's only 50%, you can fix it. If you've had no symptoms, 60%, you can fix it. A lot of the studies that were done on this were done back in the 90s, where the best medical therapy was a full dose of aspirin. Now we have better drugs out there. We have aspirin. We have drugs called Plavix that are similar to aspirin. Some folks that get stents get them put in. But the cholesterol medications, the Lipitors, the Crestors, not only do they lower your cholesterol, but they reduce the inflammation in your arteries. And that inflammation is a direct trigger for why stuff breaks off and goes downstream. So they kind of put it into somewhat of a quiescent phase for a long period of time. So medical management has come a long way, and there's a lot of value to it, which is why most of us feel comfortable waiting. Yeah.
So it's really important to take that cholesterol pill?
I would, yeah. Yep. Yeah, absolutely. Yeah. Yeah, taking it. Some people get some discomfort with it. If it's tolerable, take it. And folks that have normal cholesterol but have carotid disease or blood vessel problems, I still might put them on that, not for the cholesterol, but for the benefit that the drug gives you in terms of reducing inflammation.
Are there any dietary changes a person should make, or exercise, or?
Yeah, everyone asks that. They ask if that can reverse the problem. The reality is like I said, it's an anatomic problem. All right, it's a Darwinian problem. It's a fork in the road that the body doesn't know what to deal with. We're all predisposed to this issue. Diet, yes, because cholesterol can come and be related to diet. But when you find this problem, unfortunately, the damage is already done. So there's really going to be no backtracking. I don't care what you read, what you hear, what nutrition store you go into. There's no way to get rid of it. It's an actual physical presence. And so you can't dissolve the physical presence. We haven't figured that out yet. I would always recommend a heart-healthy diet, so to speak, because high blood pressure as a consequence of a poor diet or worsening cholesterol can precipitate or create new problems down the line. And it also makes, if it affects your heart, if it affects this artery, it's undoubtedly affecting your heart. And if it's affecting your heart, it affects what I can do to help you in these other problems. So.
Okay.
Anything else? All right. Thank you very much for having me. I appreciate it.
I want to thank Dr. Malarkey